Uh, Good evening, my respected teachers, colleagues, and dear juniors. So today I would like to discuss a few things about the non-motor manifestations of Parkinson's disease from an internist perspective. So just first, before going into the details of the non-motor manifestation, just a few words about the Parkinson's disease. So it was first described by an English physician, James Parkinson. And there are 4 cardinal features, as you all know, that is resting tremor, rigidity, bradykinesia, and the postural instability. Now, it is the second most common neurodegenerative disease just after the Alzheimer's disease. And along with the motor symptoms of Parkinson's disease, we should also give importance to the non-motor symptoms, because the non-motor symptoms are often very disabling for the patients. So the non-motor symptoms, they are very prevalent among the patients with Parkinson's disease, and sometimes they are even more disabling than the motor symptoms. And another important feature of the non-motor symptoms is that some of the non-motor symptoms, especially the olfactory problems, the rapid eye movement disorders, constipation, and depression, and they often present before the onset of the motor symptoms. And sometimes rather calling them as non-motor symptoms, they are often called as premotor symptoms of the Parkinson's disease. So among the non-motor symptoms, there are several neuropsychiatric symptoms like depression, dementia, delirium, anxiety, panic attacks, etc. Then among the sleep disorders, the most important is the rapid eye movement sleep behavioral disorder. Actually, the rapid eye movement phase of the sleep, that is characterized by atony. And when there is that phase is being disturbed, then there is some aggressive behavior during the rapid eye movement sleep, and that is a very important non-motor symptom of Parkinson's disease. And patients often complain of insomnia, and that may result in excessive daytime somnolence. So autonomic symptoms, again, they are very important among the non-motor symptoms of Parkinson's disease. Among them, orthostatic hypotension, sweating, abnormal sweating, sexual dysfunction, and dry eyes are the common symptoms. And the orthostatic hypotension and dizziness, they are often responsible for the falls in elderly patient. So this is a very disabling non-motor symptom of Parkinson's disease. Next, among the gastrointestinal symptom, excessive salivation, reflux symptoms, constipation, fecal incontinence, there are some disabling gastrointestinal symptoms in the patients with Parkinson's disease. So constipation is very common among the patients with Parkinson's. Among the sensory symptoms, pain, paresthesia, and olfactory disturbances are common. Among other, easy fatigability, diplopia or blurring of vision, then weight loss or gain, they are often present in such patients. So how will we suspect patients of Parkinson's disease having non-motor symptoms? So there are some scales and scores they are being mentioned. So with application of these scores and scales, we can suspect the patients having non-motor symptoms. So about the basic pathophysiology and management of the non-motor symptoms of Parkinson's disease. So actually, we do not test the patients of Parkinson's disease for any genetic studies unless the patients present in very early ages. So among the patients who are having the PARK2 mutation, they are susceptible to develop more severe symptoms, neuropsychiatric manifestations. Depression is a very significant predictor of the disease process, and depression is present in a considerable proportion of the patients with Parkinson's disease, and they occurs due to damage of the serotonergic neurotransmissions. And sometimes the depression in patients with Parkinson's disease, they are being associated with the overdosing of the dopamine agonist and dopamine agonist therapy. Then coming to the anxiety disorders usually comprise of generalized anxiety disorder, the panic attacks, and phobia. So anxiety is often considered as a dopamine dependent event because as a part of wearing of the symptoms, they are often present and they usually respond to levodopa and other dopaminergic therapies. So all negative symptoms such as apathy and anhedonia, they are usually due to neuronal degenerations in the goal-directed behavior and reward centers. So usually these symptoms, that negative symptoms, they usually respond good to the dopaminergic therapies. Next, delusions, hallucinations, and delirium, they are often present in the during the progression of that disease process, and dementia is usually progressive, and they are mainly due to loss of cholinergic neurons in the nucleus basalis of Mayant. So one point I would like to highlight that an important differential in patients with Parkinson's disease with dementia is diffuse Lewy body dementia. So in case of DLBD, the dementia usually appears within 1 year of the appearance of the motor symptoms. But in Parkinson's disease, it usually appears late. And DLBD is often associated with some vivid visual hallucinations. However, screening for coexisting Alzheimer's disease and the vascular dementia, that should be done in patients of Parkinson's disease having dementia. So among the sleep disorders, as I have already mentioned, RBD is a common phenomena. So to treat the sleep disorders, benzodiazepine therapy is much effective. So excessive daytime somnolence, that is a preclinical marker, may be seen in 50% of the patients. Modafinil may be used in that context. And restless leg syndrome, that is another manifestation. But before, so whenever we suspect restless leg syndrome, then we should check the patients for any coexisting iron deficiency anemia, as this is the most common cause of restless leg syndrome. So among the autonomic syndrome symptoms, some overactive bladder, hyperreflexia, urgency, they are often present. Urinary retention may also occur. And among the GI symptoms, as I have already mentioned, that drooling of saliva, constipation, etc. are common. So among the prokinetics, as the domperidone cannot cross the blood-brain barrier, they can be used. Metoclopramide and other dopamine antagonists which cross blood-brain barriers should not be used. So among the sensory symptoms, pain is a common sensory non-motor symptom among the patients with Parkinson's disease. And the dystonic pain usually respond well to the anti-Parkinsonian drugs. So non-motor symptoms are often fluctuating like the motor features, and continuous dopaminergic stimulation is often helpful in reducing the non-motor complications of this disease. So long-acting dopamine agonists, 24 hours apomorphine infusion are often effective. And deep brain stimulation or of the subthalamic nucleus. So I'm not going into the details of the management portion because that will be discussed in detail by the next speaker. So just for the postgraduate students, quick summary of the principles of management in case of non-motor symptoms of Parkinson's disease. So anxiety, depression, pain, sensory symptoms, and constipation, they often improve better with the better dopaminergic control. Sometimes we much worry about the risk of serotonin syndromes whenever we are using SSRI and MAO-B inhibitors together. But in clinical practice, this is very uncommon. Psychosis in Parkinson's disease may be associated with anticholinergic, amantadine, and dopamine agonist, clozapine, quetiapine, and a recently US FDA approved drug, that is pimavanserin, may be used, though clozapine is notorious for the agranulocytosis. Parkinson's disease dementia that often affects the quality of life in patients, and the PDD and diffuse Lewy body dementia that should be differentiated, as I have already mentioned. Then orthostatic hypotension that may be managed with the elevation of the head and salt rich diet, then low dose fludrocortisone or midodrine. Then erectile dysfunction may be treated with sildenafil or tadalafil. Then rapid eye movement behavioral disorder that that patients may be referred to sleep specialist, and they are candidates for polysomnography. So in conclusion, that non-motor symptoms should never be ignored. They should be managed with importance as along with the motor manifestations of that disease. So diagnosis with these symptoms with multiple questionnaire in early stages and treating them properly with care can improve the future outcomes in the patients of Parkinson's disease. So thank you all for your patient listening. And lastly, I would like to thank the postgraduate resident of our unit, Dr. Moni Shankar Bhattacharya, for helping me in preparing those slides. Thank you all.